Welcome to Clinical Capsules from TRC Healthcare, your trusted source for practical, evidence-based updates. On this episode, assistant editor and clinical pharmacist Gina Corley breaks down dry eye disease, what causes it, and some of the available treatment options. She discusses everything from artificial tears to newer prescription drugs, and where they fit into practice, in an excerpt from our popular Pharmacy Essential Updates webinar series. This podcast offers continuing education credit for pharmacists and pharmacy technicians. Please log into your pharmacist's letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Catch new episodes of Clinical Capsules every second and fourth Tuesday, bringing concise, actionable insights from TRC experts straight to your ears. Let's take a closer look.
Now, let's dive into a review of all the different meds that patients can use for dry eye disease. And from our article, there are a plethora of different meds to choose from. So today we're going to go over some of our options and see where they fit in therapy. But first, let's talk a little bit about the background of dry eye disease. So dry eye disease occurs when tears can't adequately lubricate the eyes, which can lead to inflammation and surface damage. Patients can experience burning, stinging, irritation, or have a sensation of a foreign body, such as sand or grit, in the eye. Some risk factors include age over 50, female gender, having low vitamin A, or wearing contact lenses. Now, let's go over some things that can cause dry eye disease. Our tears are made up of fatty oils, aqueous fluid, and mucus. And there are numerous things that can disrupt this tear film and lead to increased dryness. Some examples include hormone changes, autoimmune diseases, inflammation, and allergies. Dry eye disease can also be caused by decreased tear production or increased tear evaporation, which is important to know since some drugs target these mechanisms. We'll expand more on decreased tear production and increased tear evaporation in a little more detail. But first, let's talk about normal tear production. In normal tear production, your eyes have tear glands, or lacrimal glands, that continuously produce tear fluid. This fluid moisturizes the surface of your eyes every time you blink and drains out of your eyes and into your nose through tear ducts in the inner corners. However, some people don't produce enough tears. This can be caused by aging or certain medications, along with certain diseases such as allergic eye disease or thyroid disorders, or even nerve damage in the eye. Other people can experience increased tear evaporation. This happens when the small glands on the edge of your eyelids, called meibomian glands, become clogged. Common causes of this include meibomian gland dysfunction, blinking less often, eye allergies, or being exposed to wind, smoke, or dry air. So now, before we get into meds to treat dry eye disease, let's talk about common meds that can contribute to dry eyes. These include ACE inhibitors such as lisinopril, antihistamines such as loratadine, and beta blockers such as propranolol. If patients are on any of these meds, you can encourage them to reach out to their prescriber to talk about adjusting the dose or suggest some of the OTC or prescription eye drop options that I'll talk about next. So when it comes to meds that treat dry eye disease, there are plenty of options to choose from. We'll dig into each of them in much more depth, but for now, I just want to mention them at a high level to kind of orient ourselves. So first, we have OTC lubricants and artificial tears, such as Refresh Tears or Sustain. And these work by providing lubrication and moisture to the eye. Next, we have our cyclosporine meds, Restasis, Cequa, and Vave, which help to decrease inflammation and increase natural tear production. We also have Lifitegrast or Zedra, which may also help decrease inflammation by inhibiting LFA1, a surface protein found on certain white blood cells. Next, we have perfluorohexyloctane, or MEBO, which helps to stabilize tears and reduce tear evaporation. Then we have Acoltremon, or Triptor, which works by activating a receptor called TRPM8, leading to increased natural tear production. And lastly, we have Varenicline, or Tyrvaya. You may be more familiar with Varenicline as an oral medication used to quit smoking. But Varenicline also comes as a nasal spray that's used to help treat dry eyes by increasing tear production. Okay, so now that we've got our bearings here with these drug classes, let's explore each of them and talk about some considerations or nuances with each. So let's start first with the OTC lubricants, such as Refresh Tears and Sustain. They're usually tried first line, especially for mild to moderate cases of dry eye, but can also be combined with the other therapies that I'll talk about for added relief. Patients should start by using these 2 to 4 times per day, but can increase to every 30 to 60 minutes if needed. If patients complain of more severe symptoms, we can point them to gels or ointments, since the thicker consistency can provide longer-lasting lubrication. But caution that this can also lead to temporary blurred vision. Similarly, we can suggest preservative-free formulations such as Refresh Plus if patients complain of eye irritation, although some of these formulations may be more costly. And then some oral supplements are marketed for dry eye as well. These multi-ingredient supplements contain things like omega-3s, omega-6s, vitamin D, or lutein, and they claim to work due to their anti-inflammatory or antioxidant effects. Common brands include Blink, NutriTears, and PreserVision. If patients ask about these, you can say that they may be worth a try, but point out evidence is limited. So if OTCs aren't enough, the next med we usually try is Ophthalmic Cyclosporine. It's dosed twice a day and comes in 3 different brands, each with different strengths. So we have Restasis 0.05%, Sequa 0.09%, and Vave 0.1%. Keep in mind, none of these strengths are interchangeable with each other, and there hasn't been good studies that show one is better than another. In terms of price, these meds cost about $600 to $800 per month for cash-paying patients, although the Restasis brand comes in a generic, which costs around $200 per month. Keep in mind, some insurance companies may have a preferred brand of cyclosporine, so you may see some prior auths, but most insurances will likely cover the generic. So when it comes to cyclosporine, there are a few things we want to make sure patients know. For starters, patients may experience burning, blurred vision, or redness when inserting drops, but these effects are mild and usually only temporary. And then if patients are using other eye drops, we want to advise them to wait to use cyclosporine at least 15 minutes before or after applying other drops. For instance, sometimes a steroid eye drop, such as loteprednol 0.25%, is added on to cyclosporine to help with symptom relief, since cyclosporine drops can take up to 6 weeks to start working. So in this case, we'd want to separate the cyclosporine and the loteprednol by at least 15 minutes. Next, we'll talk about Lifitegrast or Zedra. This can also be considered a second-line agent if OTCs aren't enough, and tends to help in patients with reduced tear production caused by inflammation. It's also dosed twice daily like cyclosporine, but takes much less time to kick in, about 2 weeks. But it costs around $720 per month, and there's no generic available. And then while Lifitegrast has side effects such as irritation and blurred vision that are typical of most eye drops, it can also cause taste disturbances, which is a unique side effect. So if patients complain of this, we want to instruct them to gently apply pressure to the inner corners of the eyes after administering the drops. which will help to decrease the drainage of the drops into the nose and throat. If this does not work, patients can try switching to a different drop if needed. Our next drug is perfluorohexyloctane, or MeBO. And as the brand name suggests, this one is often tried in patients with meibomian gland dysfunction, which is a condition where oil-secreting glands in your eyelids don't produce enough oil to prevent your eyes from drying out. Like most eye drops, it can cause blurred vision and eye irritation and redness. In general, lean towards trying other options first. Perfluorohexyloctane costs around $800 per month and is dosed 4 times a day, which is more inconvenient. Plus, patients who wear contact lenses will need to wait 30 minutes before placing their contacts back in, unlike 15 minutes with most other eye drops. Next, we have Acoltremon, or Triptor, which is the first drug in a new class for dry eye disease and is dosed twice per day. This med targets the TRPM8 receptor and claims to stimulate tear production as early as day 1. But for now, we want to reserve this as a last-line option. Acoltremon costs around $900 per month, and there's no evidence that it works better than other meds. Plus, almost 50% of patients reported burning or stinging upon application. Last, I wanted to touch on Varenicline, or Tyrvaya, which comes as a nasal spray for dry eyes. It works by activating a nerve pathway in the nose to stimulate the body's natural tear production. This is different than oral Varenicline for smoking cessation, which works on nicotinic pathways in the brain. And as you've probably guessed, the two different forms of Varenicline are not interchangeable. For now, save Varenicline nasal spray for patients who can't tolerate eye drops. It's dosed twice per day but costs almost $700 per month. And there's no comparative studies with other eye meds. Also, we want to keep a close eye on prescriptions since Tyrvaya sounds a lot like Triptor that I just mentioned. So, to summarize, we want to choose meds for dry eye disease based on patient and payer preference, along with symptoms and disease severity. And then there are also some non-drug strategies that you can point out to patients to help manage dry eyes. Things like limiting screen time with computers or smartphones, avoiding dry or dusty environments, drinking plenty of water, quitting smoking, avoiding alcohol, and using a humidifier can all help cut down on dry eye symptoms. Finally, I wanted to go over a few tips on eye drop administration. We want to tell patients to tilt their head back, pull down on the lower eyelid to form a pocket, and look up before instilling the drop. If that's difficult, the patient could also lie down, place a drop in the inner corner of the closed eyelid, and then open the eye slowly to allow the drop to roll in. To minimize systemic absorption, advise patients to close the eyes after instilling a drop and gently press on the inside corner of the eye for about 1 to 2 minutes. Lastly, tell patients to avoid touching the tip of the dropper to the eye since this can lead to eye infections. To help keep all the dry eye meds along with their dosing and costs straight, see our treatments for dry eyes chart on our website.
Thanks for listening. We hope today's episode gave you practical insights you can use right away. Now that you've listened, pharmacists and pharmacy technicians can receive CE credit. Just log into your Pharmacist Letter or Pharmacy Technician's Letter account and look for the title of this podcast in the list of available CE courses. We've linked the resources we mentioned and more on today's topic right in the show notes. Those links will take you straight to our websites where you'll find even more concise, evidence-based charts, articles, and tools. If you're not yet a subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. Listeners save 10% on a new or upgraded subscription. Just use code CC1026 at checkout. Have a question or a topic suggestion? Reach out using the Send Us a Text link in the show notes or email contact us@trchealthcare.com. Your perspective matters. Share your thoughts anytime to help shape future episodes. Thanks for listening. Stay sharp, stay current, and join us next time on Clinical Capsules.